Good morning, ladies and gentlemen. I would like to welcome you to today's webinar, the third in a series of webinars. So thank you very much for finding time to join and discuss with us very important issues regarding our fight to end cholera. So my name is Fred Kapaya. I'm going to be your moderator for this webinar today. And like I said, this is the third webinar in a series of webinars on cholera preparedness in the WHO Afro region. Our topic for today is cholera case management, the role of communities, and WASH in preparedness, response, and development. Please allow me to present to you and introduce our speakers for today. We have Dr. Moriketa, who is our regional advisor, infectious hazards, WHO Afro. We have Fred Kapaya, epidemiologist, cholera, WHO Afro. We have Pierre Focassi, humanitarian WASH specialist from UNICEF. We have Danish Malik, who is the emergence and environmental health WASH focal point from MSF. We have Laurent Sachs, who is the technical officer for WASH from the World Health Organization headquarters and member of the GTFCC. We have Catherine Albert, who is our technical officer case management from the World Health Organization HQ in Geneva and also a member of the Global Task Force on Cholera Control. We have Dr. Rashidatu Kamara, who is a technical officer, case management from WHO Afro. We have Tendai Makamure, who is our IPC specialist from the World Health Organization Afro. We have Dr. Susan Nyawade, who is a technical officer for risk communication and community engagement, World Health Organization based at the Nairobi Hub Afro. Please allow me to also introduce other members that may not be appearing on this, but they are members and part of the panelists. Dr. Miriam Nanyunja, who is the Hub Coordinator for the World Health Organization, Nairobi Hub. Professor Olayinka Adebola, who is our hot lead for cholera MST. We have Anton Angaluki Anjanga, who is health specialist, public health emergencies from UNICEF. We have Dr. John Masina, who is our case management and IPC specialist from the World Health Organization, Nairobi Hub. These are the presenters and the panelists that we have for today. So before we start, we have to note that this virtual training adheres to the code of conduct to prevent harassment, including sexual harassment, at all our WHO events. So this one is not an exception. This is the agenda for today's webinar. Housekeeping, as I'm doing right now. The next one is welcoming remarks to be given by Dr. Moriketa. Then we shall have objectives for this webinar. Thereafter, we're going to have introduction to the GTFCC guidance on organizing a response to a cholera outbreak to be given by Dr. Rashidatu Kamara, co-representing with Dr. John Masina. Then we'll have setting up and managing oral rehydration points and introduction to the new GTFCC guidance on oral rehydration points by Catherine Albert. Then thereafter, we're going to have a presentation on IPC in cholera preparedness and readiness. This will be given by Tendai Makamure. Then we'll have the importance of RCC in cholera preparedness and response by Dr. Susan Nyawade. We'll then have chance for Q&A. After that, we're going to have a presentation on the GTFCC recommendation for WASH activities, implementation, and WASH in preparedness, response, and development. This will be given by Pierre Focassi. Then we're going to have a presentation on the CATI, the Case Area Targeted Intervention Approach in Cholera Management. This will be given by Danish Malik. After that, we are going to have Q&A and then closure by Dr. Mori Keita. So if you look on your screen, you will see the icon for the Q&A. So that icon or feature is going to be used for questions regarding the topic and presentations. Only the questions in the Q&A will be answered during the session. However, live questions will be taken at the end of the presentation. I must emphasize here that we're going to give preference to our Portuguese-speaking colleagues so that they can have a chance to ask questions in Portuguese, and the questions get interpreted for the presenters and the panelists to provide appropriate answers. Then you also have a feature, the chat feature. You use this feature for questions regarding IT or logistics. We have interpretation in English, French, and Portuguese, and you can access these by clicking the interpretation button. So you click on interpretation and choose the language that you would like to hear. So to hear the interpreted language only, click mute original audio, as you can see. Please note, the interpretation of the proceedings serves to facilitate communication and does not constitute an authentic or verbatim record of the proceedings. Only the original speech is authentic. On live transcription, you can click on show captions and the caption would appear on the screen. To close the caption, click hide captions, as you can see on the screen. And regarding the recordings, materials, and feedback, we are saying that this session is being recorded and we take your attendance as consent to be recorded. The recordings will be shared after the session in English, French, and Portuguese. Session materials, including session recordings, will be emailed to the participants in the days following this webinar. Now, as we continue to improve our training programs, we value your feedback, and therefore, a survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will help us tailor future sessions to better meet your needs and expectations. So, ladies and gentlemen, these are our housekeeping for today. And quickly allow me to proceed and call upon Dr. Mori Keita to actually give us the opening remarks. Dr. Keita.
Thank you so much, Dr. Fred. Good morning, ladies and gentlemen. We come again with our third webinar in a series, and today we are discussing 5 topics that are closely linked. These are case management, especially how to organize an effective response to a cholera outbreak. Infection prevention and control, IPC, activities in readiness for a cholera outbreak. Equipping the community with information and strategies to protect themselves through risk communication and community engagement, RCC. Water sanitation and hygiene, watch practices to prevent and control cholera outbreak, and how to implement case area targeted intervention, call it CATI, to quickly contain a cholera outbreak. These 5 closely linked topics are very key to the effective implementation of the cholera prevention and control strategies and are in line with the global goal. Ladies and gentlemen, an effective response should aim at limiting the mortality and reducing the spread of the disease. This is done using a comprehensive and multisectoral approach, and the 5 topics we are discussing today are among the key response pillars. Having strong preparedness and readiness in case management, IPC, RCC, and WATCH, complemented by the implementation of CAT early enough in the outbreak, can help to control cholera outbreaks and subsequently minimize its associated negative health consequences. Today, multisectoral, multidisciplinary experts drawn from different organizations and agencies will discuss key elements for better preparedness to cholera outbreaks. I would like to encourage you to seize this opportunity and learn about effective preparedness and response to cholera outbreaks. WHO is grateful to all our partners like UNICEF, MSF, IFRC, among many, for this continued collaboration in the fight against cholera. Special thanks to you, all our member states, for your commitment to this noble goal. As WHO, we will continue to engage and support our member states to ensure better preparedness and readiness to cholera outbreaks. Together, we shall eliminate cholera in our region. Thank you. Merci beaucoup. Obrigado.
Thank you very much, Dr. Mori Keita, for those very inspiring opening remarks. Ladies and gentlemen, the stage is set. Let me proceed and give the objectives of this webinar. So again, I am Fred Kapaya, and I'm going to give the objectives for this very important webinar that we are having today. Our general objective is to orient our member states on how to organize an effective response to cholera outbreaks in case management, infection prevention and control, risk communication, and community engagement, and WASH. And our specific objectives, we'd like to explain to our member states how to organize an effective response with focus on the main pillars of the response. We'd like to describe how to set up and manage oral rehydration points. We also like to orient our member states on the role IPC plays to reduce the risk of spread of cholera. Would like to share the basic concepts of risk communication and community engagement and its importance in the prevention and control of cholera. We also want to describe the GTFCC recommendations on WASH activities and also to provide guidance on how to implement case area targeted interventions, CAT, to control cholera outbreaks. What are our expected outputs? We're saying that at the end of the webinar, our member states who understand how to organize an effective response to cholera outbreaks using the main pillars of the response. Our member states will be acquainted with the CAT method to quickly control cholera outbreaks. And also our member states will appreciate the GTFCC recommendations on WASH in readiness for cholera outbreaks. Ladies and gentlemen, these are the objectives for this webinar for today. And without wasting a lot of time, please allow me to call upon our next presenter, who is Dr. Rashidatu. Please, can you take it up and give us the presentation on the introduction to the GTFCC guidance on organizing a response to a cholera outbreak. This is on case management. Dr. Rashidatu or Dr. John Masina. Thank you.
Good morning, everyone, and good morning, Dr. Moriketa. Good morning, Dr. Kapaya. Emeracha, please, can you share the slides on my behalf? I am Dr. John Masina. I'm part of the case management and IPC group at WHO regional office in Nairobi. And I'm standing in for Dr. Rashidatu, who was, I think she's engaged with some other commitments and she's unable to deliver the presentation, but I will try my best to fit in and do the presentation on her behalf. I would like to also acknowledge the contribution from Katie Aubati in the slides that I'm going to present. Thank you. Over, next slide, please. So a little background on just cholera is that we've seen over 1.4 billion at risk of cholera around the world, and about 1.3 to 4 million cases usually occur annually, and more than 1,000 deaths yearly have been recorded. And we know that we've got this ending cholera roadmap for 2030. And I think we all know the focus at country level and we want to have a concrete path towards a world in which cholera is no longer a threat to public health. And this is by implementing the Global Task Force for Cholera Control support to reduce cholera deaths by 90%. And with the commitment of the cholera-affected countries, technical partners and donors, as many as 20 out of the 47 countries could eliminate this disease by 2030. And we're hoping this is also part of the approach to eliminating cholera by providing technical advice to most of our member states. Next slide, please. So the strategies are usually multi-sectorial intervention, and this entails an early detection and quick response to contain the outbreaks, which is very, very important. And this is through interventions like robust community engagement, and I'm sure we are going to have a presentation on community, the risk communication and community engagement, and also strengthening early warning surveillance and laboratory capacities. A targeted multi-sectorial approach is usually encouraged, and the focus on hotspots, and also applying other interventions like WASH and OCV, which I think we've discussions over in the previous series, and an effective mechanism of coordination for technical support, advocacy, and resource mobilization and partnership at local and global level is really, really important. And this is what Global Task Force for Cholera Control has been working on. And usually a country-led cross-sectional cholera control program is of utmost importance. Next slide, please. So, like I alluded to, early detection and quick response to contain the outbreaks is really, really important. This decreases the mortality and aims to better adapt the case management practices and address excess mortality in otherwise treatable causes. And we know no one should die of cholera, even in bigger outbreaks. And this should be our aim as a case management pillar. Next slide. So to effectively mount a response, Coordination of the teams, especially in case management, is really important. The coordination might be intra-pillar coordination, and also inter-pillar coordination becomes very, very important. These, depending on the context in which the country might be, these teams might be pre-existing if you've been responding to most of the cholera outbreaks, but sometimes we may need to establish specifically during an outbreak, and that becomes very important. So at national level, the teams will be able to support the Ministry of Health to adapt updated standard treatment protocols and coordinate and organize SAGE workforce capacity. Then the field teams should be available to provide clinical mentorship, ensure collection of useful clinical data elements, and conduct regular assessment of treatment units, including ORPs. And then at subnational level, very important to establish emergency operation centers at subnational level to ensure coordinated partner and stakeholder response to meet the demands of the outbreak, and also the demands of the preparedness if it is in preparedness mode. The picture on the right side just shows a technical working group meeting in one of the regions in Ethiopia during an outbreak. Next slide, please. Another important aspect of preparation and also response is the preparation of updated clinical data record forms and job aids. This is very, very important and cardinal. These record forms informs clinical strategies. How are you going to change the strategies? Also informs population at risk of mortality and factors associated with mortality that can be addressed, and also becomes very important in assessing the severity of the disease. This leads to improvement in patient outcome as well, patient follow-up, and also these forms should be well adapted and should be customized according to the country situation. Patient factors like vaccination status, the comorbidities, and the concurrent outbreaks are really, really important to also record. On the right side, again, we've just given some examples of clinical data record forms used in Malawi in the previous outbreak, and these were adopted from the GTFCC guidelines. Next slide, please. So the network of care is also another important aspect that I think we need to bring to light. The use of epidemiological data for current and past outbreaks to identify high-risk areas is very important. And I think Dr. Kapaya will have another talk on these multi-sectoral areas where it needs multi-sectorial intervention, and also areas with poor access to water and sanitation. We have to map these as part of our preparedness and also as part of the response, and then take into consideration barriers to access to care. That becomes very important geographically, or economically, or social. And I think Dr. Katie Albert, when she comes to talk about ORPs, this will be actually the center, because access to care is one of the most important aspects of a response to a cholera outbreak. Next slide, please. So we have three main levels of care, and the community level, which is the oral rehydration, which I think we are going to talk about in detail in the next presentation. I'm going to talk about briefly on the standard oral and intravenous care, and also just the oral and intravenous rehydration treatment of complications and comorbidities. These are the two aspects of proper case management care, which is the cholera treatment units and the cholera treatment centers. The community level oral rehydration points, Dr. Katie Albert will give more insight in the next presentation. Next slide. So community level oral rehydration, I'm just going to give a brief outline on this, and then Dr. Albati will give more insight to that. So this provides oral treatment for patients with acute watery diarrhea and dehydration, and refers patients. So it's a point of referral from the community to the CTU or CTC. And it might also act as a point of entry into the community for community interventions and community risk communication and community engagement. So the two pictures are just showing oral rehydration points, one in Malawi, and then the other one, the setup in Ethiopia. So these are actually managed by lower cadres in terms of the training, and they are only daycare facilities. Next slide. And then the standard oral and intravenous care, also this traditionally referred to as a CTU. In most cases, the structure will be part of the referral system. And actually the referral system will be from the community to the ORPs, from the ORPs to the CTUs or to the CTCs. This provides a referral for patients with medical complications to their higher levels of care. And this can be set up next to the health facility, or can be set up as a standalone stabilization center. And care is provided at a fixed site with usually open 7 days a week. And the infrastructure for receiving patients for 24 hours should be provided. The size usually varies between 5 to 40 beds. And this can be set up with local materials, as you can see on the picture on the right. The triage and stabilization center being set up just using local materials in one of the centers in Malawi during the 2023 cholera outbreak. Next slide. Then we are coming to the last level of care, which is the treatment units, the treatment centers. This provides oral and intravenous treatment for rehydration. This is for treatment of a comprehensive treatment of cholera patients, those that have comorbidities, those that have complications. These staffs are well trained. They support community level oral rehydration teams and teams from other treatment centers, and receive transfers from these units. And the care is provided on 24 hours basis. This type of center usually has above 40 beds to 200 beds. The one on the picture shown there is one of the centers which was set up in Lumbazi in Lilongwe. It had 35 beds, and these beds were able to be scalable to up to 50 beds with a dedicated unit for pregnant women and pediatrics. Next slide, please. So the minimum standards that we are talking about in these centers also becomes very important. All staff must be trained. And I think this should be part of the preparedness to train staff and also to retrain, because one training is not sufficient. Most of the times we have seen attrition of healthcare workers, and it will be very, very important to stage these trainings more frequently. And also what is important is these individuals providing community level oral rehydration should also be trained on how to prepare the ORS, the case definitions, and how to refer patients, and part of the record keeping, you have to provide them with at least a referral ticket, which I think Dr. Albati is going to talk about when she talks about the oral rehydration points in the community. And then the standard oral and intravenous care staff should also be trained to identify patients with complications and comorbidities, very important. And the cholera peripheral kits is actually designed to support these scenarios of the community level and the standard oral rehydration and intravenous care levels of care. Next slide. So now the CTC, again, the same principles and standards actually apply. Staff at this type of structure should be able to take Store samples and safely package and adequately label samples for transportation to the lab. That's for both for confirmation and also for determination of at what level, depending on what level of the epidemiology you are in the outbreak. So at these higher levels, we should have these facilities, and staff should be trained to keep a register of patients on appropriate recording of individual data. At this level, additional support such as registrars, cleaners, laundry staff, because these are bigger hospitals that are going to run. Sometimes they are adjacent to a health facility. Sometimes they are actually standalone facilities, and they should be able to provide care to a comprehensive care to cholera patients. And usually, the central cholera kits are designed to manage these treatment units. Next slide. So the use of caregivers becomes very, very important as well. Each patient may have one caregiver, though sometimes it's very difficult to control patients, but it will be good to have some control on how many patients are being admitted, what the caregivers are giving to these patients. And sometimes the caregivers can learn how to help care for the patients, like those patients that are on oral rehydration. They can encourage them to take these fluids, and we can actually give them the knowledge on prevention or on infection prevention in the community. And also they can also act as ambassadors in the community when they go back with their loved ones back into the community. So they act as a pillar between the center and the community as well. Next slide. So these are just pictorial slides just to show how these treatment modalities are interlinked. So we've seen the ORIS. We are putting that as part of the oral rehydration points, and these lead to the referral system is in such a way that it takes the patient to the centers where ORIS and IV fluids can be given. That is either a CTU or where ORIS, IV fluids, and complications can be treated, and that's a CTC, Cholera Treatment Center. Next slide. This is also just to illustrate the referral pathways that are really important, and all the referral pathways should be centered to taking patients to centers where a comprehensive care that includes ORIS, which is oral, and IV fluids can be given to the patients, and treatment of complications. I think this should be my last slide, Emiracha. Next slide, and I think I should. Yeah, so thank you so much for listening, and over to you, Eme and Dr. Kapaya. Thank you.
So thank you very much, Dr. Masina. Very comprehensive, very important. And ladies and gentlemen, it is very important for us to understand how to organize a response. And this is exactly what Dr. Masina has done to show us what we are supposed to put in place to make sure that we have an effective response. That said, let me quickly call upon Catherine Albert to give us a presentation on the oral, setting up and managing oral rehydration points, and also an introduction to new GTFCC guidance on ORPs. Katie, you can take it up. Thank you.
Thank you very much. Thank you very much to Dr. Messina as well for his great presentation. As he said, mine will really is a complement. And what I'm going to be focusing on, as was said, is on decentralizing treatment into the community. So why are we really focusing on decentralization? What I'm going to show you on the next slide is that in 2022, the GTFCC conducted a scoping review on the risk for cholera mortality. And what we saw was really quite shocking, I would have to say, is that 22 to 86% of reported deaths occurred outside health facilities. This is in the community or while people were traveling to a health facility. And decentralizing treatment into the community can really improve access to treatment, and it must be a priority to reduce these deaths. And I think, sorry, I'm having a little trouble with my screen. There we go. So if you see the results from this survey, and this is from the scoping review, so this is a published literature. What you see on this screen is that any of the yellow or orange deaths occurred outside health structures. And I think this is an area that we have not been putting enough attention to. What we see is that all the focus goes on to CTCs and CTUs, which are of course extremely important. I'm certainly not going to say that they're not, but what we do is we wait, and that treatment in the community, improving access, becomes secondary. And we really have to make it a priority and make sure that this type of activity is planned from the outside. It's part of preparation and readiness, and that it's put in place as soon as an outbreak is detected. So just again, these are, you know, all of that. It's a range of countries from everywhere across the world, and this is over a period of 15 years. So as I said, why are we trying to do this? We really want to ensure that there's access to ORS in the community. How that's done is going to be context specific, and I think that's part of preparedness and readiness. It's important to identify what resources are available in communities, at-risk communities. And I know there was a previous webinar on the identification of priority areas for multisectoral interventions, PAMIs, and this kind of a survey or finding out what resources are there can be done in those areas. What we often exists is community health worker programs or IMCI, local volunteer programs, and that can be women's groups, it could be youth groups, for example, it can be Red Cross, Red Crescent volunteers. I think we have to think very broadly. ORS, as Dr. Messina said, it's not complex, and we can teach people how to give it correctly, and this can really help save lives. But if we've identified these groups in advance and have figured out how to reach them, then it's much quicker to set up this kind of program. And even just one trained person in a community can give ORS. So that could be this was done in some countries, including Sierra Leone. In the past, they had a blue flag program where somebody in every village was trained. They had a blue flag on their house, and that everybody knew that there was ORS in that house. So again, this is just things that can be used, and with readiness and preparedness, especially in at-risk areas, this is something that can be already in place. So those first people who get cholera already know that they can go to these places to get ORS, and we can potentially prevent the first deaths, which is really important. Obviously, the other way to deliver ORS in the community is through what we call oral rehydration points that was mentioned by Dr. Messina in the previous presentation. To succeed, ORPs need to be well integrated into the community. And I think this, again, Dr. Messina mentioned it, the importance of coordination, and it's this multi-sector coordination. As I said, using existing programs can be very useful because people already know them, it's already members of the community. And otherwise, partnering and collaborating and working with our risk communication and community engagement, different names for different agencies, but I think we know what we mean, can be extremely important. They can facilitate integration into the community, and they should be the first point of contact with the community. They're much better at it than case management colleagues are, and that's what's referred to as proper entry. They can facilitate discussion on the sites, on staffing, on who can be volunteers, and taking that additional time can really change the outcome. It can ensure that instead of having a rejection, instead of there being doubts or fear about why this ORP is there, people can misinterpret and think that it's going to bring cholera into the community rather than it being a point of contact for them. And those colleagues can really be part of that response. I think one example we can give is sometimes it's easier to explain that, but this was done in Malawi, where the risk communication teams went in, they talked to the communities, they helped identify sites and volunteers. And then the next day, the case management colleagues went in and did the training. And this worked extremely well. And what we saw is that even in some communities where they had regularly seen cholera in the past, even when centrally the idea was to start closing ORPs, some communities said no. They said that they were going to keep the ORP open to be able to serve their communities. And again, we keep using this term ORP, and Dr. Messina did mention this briefly. So an ORP is usually a temporary site, as was mentioned, only open during the day, and it only provides oral rehydration for patients with suspected cholera. And again, we're just going to keep emphasizing this, that the objective is really to have that very early access to treatment. Getting ORS early on can save lives. Some people, it's all they'll need is that ORS. Others will need to be transferred. And again, so it's that aspect, and it also helps to keep people who don't need to be at a higher level care. They don't need to be to CTC or CTU. Then they stay away from those bigger centers, and that helps the quality of treatment in those centers as well. And again, just to give a field example, I was very lucky to work with Dr. Messina, and over the last year, we were in South Africa. There had been a center that was extremely busy. But it was quite far from the affected center. It was a very good site. They had good skilled people. They had excellent infrastructure. But again, the issue was distance. And when they set up the equivalent of an ORP, was a bit more complex, but they had an ORP. It really decreased the pressure on that that hospital. As I said, good quality hospital. And when we asked the senior staff what they thought about this fact that this ORP had been set up, they said they were extremely happy with it. And what was happening is that they received patients, they weren't as severe. She used the term, this was a term of they were no longer on the brink, meaning that they were no longer on the brink of dying when they arrived at the hospital. And for me, it really illustrates the benefit of an ORP is that these people were getting the initial treatment closer to their community. And then in that case, they also had an ambulance system that they could bring them to the hospital where they could receive full treatment. I think one thing as well is that what an ORP looks like will vary significantly from place to place. It might be in a treatment facility. It might be just somebody with a bicycle and a kit. It might be a temporary structure that is set up. So this, for example, could be an ORP. It's quite busy with a lot of other things going on, but it can be, that can be transformed into an ORP. And this was in a health center. And that's quite frequent. One of the benefits of an ORP being in a health center or in the compound of a health center is people know that it exists, or a health post, something that's very close to the community. This is another option. This is something where they've just set up, you do want to protect both the volunteers and the patients from the elements. So it's good to have a roof if possible. This obviously is a Red Crescent ORP. And as what you see is you don't need a lot of infrastructure. And I think that's something that we need to be very cognizant of, is that these need to go up quickly. So it can be relatively simple. Apologies, I didn't realize this wasn't the greatest quality photo. I think I took it, so I'll stick with my main job and not become a photographer. But this, for example, was on the edge of a market in Malawi. And this brick structure was a market stall holder had volunteered to have it used as an ORP. And again, that was somewhere that was very easily accessible. So once we're getting to location, I think one of the things we should be thinking about is how far people would have to go. Ideally, you don't want them walking more than 30 minutes. I think most of you have seen the state that patients can be in. And you want them to be able to get ORS as quickly as possible. That's the benefit, for example, of some of the programs, like just having some ORS in every village that's at high risk, and decentralizing as much as possible is to get that first mugful, as it were, or cupful of ORS into the patient. So where are some of the priority areas? and this again is part of this coordination that was mentioned by Dr. Messina, is we need to be coordinating all the data and looking at the data. And the epidemiologists who are getting the data can help by saying, there are a lot of reports of deaths in this community from this treatment structure, and the people are coming from this community, or they're getting reports of community deaths. That can be an indicator for an investigation and to set up an ORP. It might be that there are a high number of cases reported from somewhere, highly populated areas, difficult to access areas. And I think something that we sometimes overlook is the fact that there are no cases reported from somewhere. It doesn't mean that there are no cases. No report may mean that there's no access to treatment, and therefore it may be somewhere and people just aren't getting to treatment and they're in fact dying in the community. And there have been a couple of surveys that have shown this. So when you see sort of if somebody's got a very good map and there's a gap, that may be somewhere to go check as well, because it may mean that people just aren't accessing care. And in rural areas, can be a very big issue. The numbers may not be high, but access can be extremely challenging. And it's something to think about, is having somebody, and again, this can be very simple. It can be just a tent and one person with ORS, but on main footpaths or areas, people may not be traveling in the ways that we think of. We might be on the main road and think, well, there isn't really anybody living here. But when you go up into the hills, that may be a very different situation. And that's why the local knowledge is so important as well. And as I said, no reported cases may mean there's no access, not that there are no patients. So what do people need to be able to do? As was said earlier, and Dr. Messina, ORPs are not staffed by highly skilled healthcare workers. It can be, and if that's the case and there is enough staff, then it's great, and they can probably have a broader scope of activities. But the minimum is that they can apply case definition, so they can see that they can ask that the patient actually has diarrhea, that they can assess dehydration, at least a minimum, and they know who to be able to refer on for additional treatment elsewhere, that they can initiate, so they can make ORS safely, and then they can initiate giving of ORS, that they can be part of community-based surveillance if that's occurring. They are also a great source of information for health and hygiene messaging on prevention. Even when there are no patients, people will get to know them, and if they can provide information, they're a great source within the community for that type of information. And if that's happening, they can be used to distribute key supplies, such as ORS, both at their site, but elsewhere. I do think one thing that we don't look at enough, is transport. And we often say refer, but that means two things. One is that transport, and it's in some cases, what they'll do is if they arrive with a referral ticket, then they might be paid for their transport. And that's what some agencies have done. There may be, in bigger sites, they may have an ambulance system, or they may just have, you can hire maybe a moto transport who's just goes back and forth and back and forth and back and forth from busy sites. And I do think that that's something that we don't think about enough, and we probably should. And the other thing is that whenever you're referring a patient, they should be referred with made up ORS so that they can continue to drink during the transport. And that's something to think about as well. So the core thing for ORPs in terms of what you need to have is they need clean water. So whatever is provided, you need to be able either to be close to a water source. If the water source isn't clean, you need to provide a way to make clean water. So that can be either with a filter or a household water treatment. Whenever possible, hand washing facilities, latrines, you do need to ensure IPC, and think of, as I said in those pictures, protecting the staff and patients from the environment. If it's a more stable site, you can do more, but I think we just have to sometimes keep to the minimum. If we make an ORP, if the idea of an ORP too complex, then it's less likely to be set up. And the most important thing is to have clean water, make safe water, not clean water, safe water, make up ORS, and make sure that it's getting into patients. supplies, most materials from an ORP can be bought locally. ORS and zinc, and in fact, water treatment products as well, are the only materials that usually have to come from outside. Both WHO and UNICEF and the Red Cross Red Crescent societies have ORP kits. I will correct that before we share this presentation. And although the kit would only be supplied once, we do have to think about supply management, because ORS and any water treatment products, etc., will need to be provided regularly. So just this is the minimum. The UNICEF, WHO, and IFRC kits, the old kit anyway, are very simple. And what you'll see is that this is a water filter on the left, and all of the products actually fit into that filter so that it's easily transportable. And it was designed, in fact, to be so that it can be put on the back of a bicycle. The IFRC kit is now a bit more complex, but this remains the UNICEF WHO kit. One thing I will say is that you do also have to think about supervision. That whole descent network needs to be integrated, and the ORPs need to be integrated into that case management response. And then regular supervision does need to be planned. So you do need tools such as supervisory checklists, stock management, as I mentioned, and depending on both patient flow at structures or within ORPs, then the supervisors can help determine whether a new site should be opened or whether a site can be closed. So what are some of the elements specifically for preparedness and readiness? Is knowing the community systems that are in place and that can be used. Ensuring that the decentralization of treatment and ORPs is part of the priority, that it's part of the strategy, and that it's not a secondary piece, but that the setting up of the entire network is prioritized. That it's very clear within the plans of who will be overseeing ORS points or ensuring that ORS is available in communities. Developing of guidance and tools to support ORS, translation of materials into local languages so that all signage, those kind of things, are in local languages, and consider even setting up ORPs as a permanent structure, or ensuring that ORS is permanently available in PAMIs, as I mentioned. And this is just some examples of some of the tools that can be developed. This is a supervisory checklist, is the one in colors, a referral form, signs that could be translated in advance of how to make clean water, how to make ORS. Those kind of things can be developed in advance and translated. And as was mentioned, so the GTFCC Case Management Working Group is currently developing a whole package for the setup and management of ORPs. All of these tools are actually from that. So in fact, hopefully it'll be available in the next month. And this is the kind of thing that in preparedness, you can be translating some of this into other languages for your own country. I think my last points, I'm going to run out of time otherwise, is that ORS was actually developed for cholera. I think it's something that has been, somehow this information has been forgotten, but ORS was developed to treat cholera. It was at ICDDRB in Bangladesh. What they did is the mineral and the electrolyte content of ORS was made to match the output from cholera stool. There have been slight modifications since, but I think that's a key message that we need to be passing, because sometimes people don't think ORS is enough. They think they need IV therapy when ORS will save them, and it's maybe all that they need. And I think if people know that this was really developed for cholera, and that's both clinical staff and the population, that might be able to help change the image of ORS. Early treatment with ORS does save lives, and we need to make ORS a priority in cholera response. And then this is part of it. I just do want to refer you to the GTFCC website, so gtfcc.org/resources. This site is available in English and in French. And the ORS package that there'll be resources to on there. And there's also the GTFCC app, which will also have some additional resources. And I will end there. Thank you very much.
Thank you very much, Katie, for a very, very good, comprehensive presentation. Ladies and gentlemen, I think this is the way to go. We need to ensure that we understand and appreciate the importance of ORPs to try and reduce the case fatality rate that is usually associated with cholera and also the severity. So thank you, Katie, and we'll be able to share these materials to all of you after in the days after the webinar. At this point in time, quickly, I'll call upon Tendai Makamure to give us a presentation on infectious prevention and control. Tendai.
Thank you very much, Dr. Kapaya. Good afternoon, colleagues. Good morning. Can you confirm?
Your presentation, can you stop sharing?
Can you hear me, Dr. Kapaya?
Yes, loud and clear. You can go ahead. I'm just asking.
Yes, just let me
Katie
stop. I'll stop. Thank you.
Tendai, you can go ahead and share. Amarach, can you share for Tendai?
Thank you very much, Amarachi, for the support. So, ladies and gentlemen, my name is Tendai Makamure. I support infection prevention control. I'm with WHO based in the Nairobi hub, and I'll be taking you through preparedness and readiness for cholera on the IPC components. Next. So we're just going to talk about the rationale of why it's important IPC preparedness, and also go through the IPC outbreak preparedness, readiness, and response framework. We'll also look at the target audience and also key activities we will undertake in preparedness and also in readiness. Next. So for the rationale, we all understand the importance of the infection prevention control. It is to break the chain of transmission using evidence-based measures in healthcare facilities, which are very critical for us to prevent and contain outbreaks while we are still maintaining the delivery of safe, effective, and quality of care. And also strengthening IPC preparedness will also help to lead to a more robust response, contain the outbreaks, and also prevent the health systems from becoming overwhelmed. And lastly, if we invest in IPCs at the national and health facility levels, we are able as countries to mount optimal outbreak management, optimal IPC outbreak management. Next slide. So looking at the target audience, we are looking at the national and subnational IPC focal points who are responsible for coordinating IPC, the decision-making, and the policymakers who are particularly important, especially on preparedness, where we need to put the systems in place which are aligned to the recommendations by WHO. And we're also looking at healthcare facility leadership who are supposed to support in decision-making and procuring supplies for infection prevention control, and also ensuring that their healthcare facilities have meet the IPC measures that are recommended. We are also looking at the national level at the multidisciplinary IPC committee, considering the cross-cutting nature of infection prevention control, where we are also looking at people who are in WASH, in infrastructure development, in antimicrobial resistance. We are also looking at those who are in environmental. All those should be part of the National Multidisciplinary Committee, and this is done in the structures of IPC at the national level. We're also looking at the involvement of incident managers, the IPC task forces, the WASH personnel, and also the IPC stakeholders. We usually have partners in country who will be supporting IPC. Next slide, please. So looking at the preparedness phase for IPC, we are saying that this phase does not just start when there's an outbreak, it starts before an outbreak happens. And this starts from the country when they conduct their risk profile using the STAR, and they develop their multi-hazard planning, and they are mapping the potential hazards in their countries and the different capacities that they have to support the operations at the different levels to respond to emergencies. And in these multi-hazard plans, they should also ensure that we have an IPC component represented there. So this process can take 2 to 6 years in advance of any identified threat. It's the continuous improvements that we do as a country. We are also developing a foundation for IPC in outbreaks, and we are identifying the key personnel and partners who are involved. And also for the IPC outbreak plan, we should be able to audit and test the system as well during preparedness. Next slide, please. So I talked about the minimum requirements. We are saying that in preparedness, as we are doing continuous improvements, we need to ensure that at the national level and the facility level, the minimum requirements are in place for infection prevention control programs. And how do we define these minimum requirements? These minimum requirements are defined as the standards that should be in place at the national and facility level to provide minimum protection and safety to patients, healthcare workers, and also the visitors, and they're based on the WHO core components of IPC program. And we are also saying the minimum requirements for low to medium income countries. These are the starting points where we put the requirements in place, so we ensure that we build a journey for IPC. So how do we put these minimum requirements in place? Next slide, please. We should ensure that at all levels, and we evaluate our IPC capacities at the national level and at the facility levels to ensure that the minimum requirements are there. Once we have done this assessment at the national level, we have been supporting countries to do these assessments using the Infection Prevention Assessment Control tool for minimum requirements at the national level. You develop 5-year strategic plans, which have an M&E plan and an annual operational plan. And we also, to ensure that we have a best response to public health emergencies. At the facility level as well, we have the tool which is used to build sustainable IPC, which is called the Infection Prevention Control Assessment Framework for facility level, which is again focused on these minimum requirements. So after this assessment, we also need to ensure that we develop an outbreak management as a component of our national IPC program, ensuring that we have the budget dedicated for IPC, which is in preparedness for any outbreaks. Next slide, please. In the national preparedness plans, our role in infection prevention control at the national level is to ensure that we also include the IPC components that are there in the cholera outbreak preparedness plan. And for the IPC component, we need to outline what the objectives and goals will be, and also to make sure that we identify the IPC National Task Force, which should be part of the development of the plan and included in developing that IPC component. And also this component should outline the training plan that will be done for IPC. If it's for cholera, it's for cholera, an IPC training plan for cholera, including the drills, the simulation and tabletop exercises that will be done as well to test the IPC outbreak plan. In this plan, we also need to make sure we have quantified the PPE stock supplies that will be required and anticipate PPE burn rates to avoid shortages. Next slide, please. Then the second component, which is quite critical and also aligned to the minimum requirements, is having the national IPC guidelines, which are consolidated and evidence-based at the national level. And in these guidelines, the outbreak component should be included, including the SOPs on standard and transmission post precautions. And these guidelines, they should be available in the facilities, and there should be a system at all levels to monitor the adherence and the compliance with the guidelines recommendations. Next slide, please. Then also we move on to training. We need to have a national program for training, and we need to have surge capacity rapid response teams who have been trained, adequately trained on IPC for cholera. And also as a national program, there should be an institutionalized IPC curriculum, which has overarching principles on IPC, as well as training for specific standard and transmission-based precautions for cholera. And we must ensure that all the healthcare workers in our facilities, they meet the basic competencies in IPC practices, and we should include hands-on training, hands-on supervision, and also multimodal teaching formats, which include hand hygiene and donning and doffing of PPE. The training should be practical so that all healthcare workers can respond to cholera. Then these are the standard and transmission-based precautions, which I outlined in the previous slide, that we must make sure that they should be trained, and I won't go through each of them, but the standard precautions, we are saying these are measures which should be applied at all the times by all the health workers. Each time you meet a patient, standard precautions should be applied at all the times to prevent the transmission of pathogens. And when it comes to cholera, we'll have specific additional precaution measures, transmission-based precautions, which should be taken into consideration, considering the fecal-oral route transmission, the mode of transmission of cholera through contact. We should ensure that there's isolation facilities, signage and posters which indicate where isolation is doing, and pathway of flow of patients within the facilities. We should have the relevant PPEs that the healthcare workers should have to prevent also acquiring pathogens, the Vibrio cholerae, and also transmitting it to patients, dedicated materials and equipment, and also considerations for patients' transport and movement, and specific communication on IPC measures for cholera. Next slide. Also, what should be available at both the national and subnational levels is IPC communication strategy, and there should be collaboration with risk communication and community engagement, so that we develop the communication strategies for which include IPC messages targeting healthcare workers, the healthcare facilities, the communities, the public, and also through social medias and any other means, messaging channels that can be identified. There should be identified designated spokesperson who are supposed to do trainings on this, and in other countries they do media dialogues or press conferences to transmit all the necessary information on how to prevent the transmission of cholera. And also we should identify scalable messaging channels that can be easily activated in the outbreak situation. So all this should be in place during the preparedness phase. Next slide, please. Again, as I mentioned, surge capacity plans for IPC resources. We need in the preparedness plan where we are developing the IPC component, we need to make sure that the plans for IPC resources are there. And we need to have ways to manage capacity and ways to monitor the availability. We plan for IPC supplies with the operations and logistic partners. We also have an estimate in the plan for increased IPC personnel requirements during an outbreak situation to ensure that we always have adequate staff who can support the CTCs or the CTUs, and also continue providing essential health services during an outbreak. And in these facilities at the national level and the next level, we should have the plans, the inventory of available staff. Their levels of training is important so that now when it's an outbreak, we are not running around looking at the planning trainings to say the health workers have not been trained. This should be all documented in the planning phase, and develop a system as well of monitoring healthcare capacities and also the IPC resources required. Next slide, please. Then now when we move into readiness, we must ensure that all that I've listed above are in place, and we must be in a position where we are ready to activate the IPC response mechanisms to cholera. We must prepare the key personnel and the partners who are supporting IPC, as we outlined in the first. In preparedness, we have done partner mapping and stakeholder mapping. We know where they are, and they are also aware of the response plan we have developed. We also assess our readiness in IPC by doing the simulation exercises which focus on IPC measures and setting up the CTUs. We also try to identify gaps and deficiencies in the performance after in areas such as set capacities in supplies in readiness. Next. Then also, as we are in readiness, we must make sure that we are familiar with the IPC measures, which should be there in the CTUs and CTCs, the recommendations by WHO and the Global Task Force for Cholera Control. And the tool that is used to assess this is the CTC-CTU assessment, which is used by the trained assessor who's trained on IPC and case management. And it assesses the implementation of standard precautions, PPEs, cleaning and disinfection, sanitation, waste management, laundry, food hygiene, preparatory of dead bodies, and also CTC assessments. I'll quickly go through these assessments in the next slide. Next slide, please. So for PPE, all the staff who are going to the CTCs, they should have, they should at least have the scrubs that they use to go into the PPEs. It's important on this slide to know that staff should not leave the CTC in their protective clothing, neither should they work in the CTC with their personal clothes. And the PPEs, you can see them on the right. They can include the scrubs there, one pair of boots for staff who come in contact with patients, with corpses, with waste, and also for staff who are not exposed to projections in the kitchens, the rubber clogs are sufficient for them. Next slide, please. For cleaning and disinfection, the 3-bucket system is recommended where you wash, rinse, and disinfect. And we have steps that are outlined there on the steps of cleaning, and all the healthcare workers should be trained on the stages of the 3-bucket cleaning technique, where you wash with soap and water first, then you clean the surface, you rinse with clean water, then you put the water in disinfection solution, which is chlorine, and you disinfect the surface. Next slide, please.
We can
also,
just,
we must
try to wrap up quickly. Thank you.
Okay, I'll quickly go through this. We should also take note on the chlorine solutions that are different for different activities, 2% in washing of dead bodies, and also for cleaning patient and toilet areas, we are using 0.2%. For disinfection of patient seats, 0.2%. And also for hand washing, the recommendation is to use soap and water. But if on the last resort, when we don't have, we use 0.05 chlorine. There should be dedicated toilets for patients who are in the CTCs and CTUs, and we must make sure that there are dedicated hand washing facilities in the dedicated latrines so that patients are not going to other patient areas to look for hand washing facilities. Next slide. Then for waste management, it is important to understand the waste management processes and to note that the waste generated in the CTCs or CTUs, it's all infectious, so it should be treated separately. However, in the CTUs, the segregation should still maintain the 3-bin segregation where we have general waste, infectious waste, and also sharps waste. And the waste, where the waste is collected from the CTUs, it should be marked with fence so that it should not be mixed with others. For the laundry, as we have said, the laundry and that is coming from the CTUs and CTCs should be washed separately and should be immersed in 0.2% chlorine for 10 minutes for contact time, and then washed with soap and water and air dried as well. And the slab where these materials are washed should be disinfected with 0.2% chlorine solution. Next slide. For food hygiene, ideally food should be cooked and prepared within the healthcare facilities, and also healthcare staff should be trained on basic food safety practices. Our patients and caretakers and staff, they should not take leftover food home. And we must also make sure that the utensils that are used, they are washed with soap and water and disinfected with 0.2% chlorine. Next slide. I am about to wrap up. In the preparation of POPs, we talked about the body. It should be washed by washing and not spraying with 2% chlorine, and make sure that all the orifices are plugged with 2% chlorine. And in the preparation of the cups, the trained staff trained in IPC should wear the appropriate PPE, the gloves, a mask and a gown. And also for cultural reasons, if family members want to participate in the process of body preparation, they should be adequately trained by a knowledgeable staff member and provided with a relevant PPE. For movement of bodies, body bags should be used to transport the body for burial. And if there's no body bags, an absorbent cloth or towel soaked in 2% chlorine can be used for that, and also plugging, making sure that it's covering all the orifices for potential fluids during transportation. Next slide. And we must also, for making sure that we have all the necessary materials and equipment, we talked about quantification of all the supplies that will be required, and the food, they should be done and be maintained with the CTC in the CTU. There's also online this website where the link below for WHO, where there's an online cholera kit calculator, which is available to plan, to make estimates for what you need for planning for cholera response. Next slide. Thank you. So ladies and gentlemen, this is a nutshell of what we must do. And I think the key message is ensuring that we have sustainable IPC, the minimum requirements are in place at the national levels and in the facilities. Thank you so much. Over to you, Dr. Kapaya.
Thank you very much, Tendai, for a very comprehensive, very important presentation on IPC. And I'm sure participants have really enjoyed. It's very great. Thank you, Tendai, for that presentation. And quickly, I'm going to call upon Dr. Susan Nawade to give us a presentation on RCCE. Dr. Susan.
Thank you very much, Dr. Kapaya, and thank you to colleagues who have come before me. That set the stage for me, and so it should make my work easier, because I might just need to refer to what everybody else has talked about, because really we play a supportive role, and most of the messages that have been referenced by IPC and everyone else are basically what we also need to pay attention to ensure that we are ready. Many times RCCE comes in after the outbreak, but we are saying that we really need to be ready before the outbreak. And so we need to communicate about not just prevention, but also tell people what they need to expect if there is an outbreak, so that we don't have the so-called refusals or rejections. So I'll be presenting on behalf of the RCCE team. I work at the emergency hub in Nairobi for WHO, but we work closely with other partners, including UNICEF, IFRC, as well as colleagues at country level, and most importantly, the member states. So in terms of the outline, and to just, the first two slides will be pretty quick. This I like having here because it's a kind of reminder. I don't want to assume that everybody knows what we need to do with RCCE or how we go about it. And then we look at why we really need risk communication and community engagement. And as I've mentioned, there's been a lot of reference to this by Dr. Masina, Dr. Alberti, and also Makamure. Principles of community engagement, and then specific activities or what we really need to do before the cholera outbreaks. Just a kind of outline, because with 20 minutes is not enough time to really go into the details. And then I'll conclude. But when you receive the slides after the conclusions, there'll be a number of slides that are sort of just flash through towards the end. So this is the overall or overarching goal for RCCE. And if we were just to pick what is underlined, it needs to be people-centered, community-led approaches, because many times, sometimes we want to go in with our solutions that may not necessarily be practical. If we do this, ensure that we are led by what the community is able to do, we'll be able to increase trust and also the social cohesion. because they'll realize that we are also listening to them. And then in the process, we'll be able to reduce the negative impacts. So in terms of strategic objectives, I've already alluded to that in the goal: be community-led, be data-driven or evidence-based. And this is not just evidence that we are collecting, at the point when we need it. For now, a number of countries have already had cholera, for example. Some have declared it over. Others may be prepared and it did not come, but there's something to learn from what was done and also from what we missed because of lack of preparedness. So we need to use that kind of data. The first session was on priority areas of multiple intervention. So once we know these, what were usually called the hotspots, we need to ensure that we have the right data to be able to respond. Reinforcing or strengthening local capacity and solutions. Yes, we want it to be community-led, but we must build their capacity, sensitize them, and ensure that they do it right. And being collaborative is important. We're already talking about multi-sectoral approach. And of course, we know that there are very many sectors that we engage. Specifically, we get concerned in RCCE because just providing messages is not enough. Most people hear RCCE and they assume that all we need to do is tell people what to do, but there's much more to it than that. When you look at some of the structural issues, you might be telling people to wash hands, but if there are no hand washing facilities, it's a problem. You want them to use clean water. If it's not available or the supplies to make it clean are not available, that is problematic. So we really need to work with others in other sectors. The definitions, I don't want to go into this. Real-time exchange of information. So most of the time, this appears to only apply to when the outbreak is already there. But I think even before, we need to be able to address any questions that are coming up. Community engagement, that is the whole essence of being community-led, ensuring that the community are participating at all levels, providing information, engaging them, making decisions together, and then taking action together. So why do we need RCCE? In a nutshell, this is not exhaustive, but some of the issues are because it addresses low-risk perceptions, which I think many member states will agree with me that it is a major barrier, not just for cholera, happens for other outbreaks as well. Low or inadequate knowledge. Sometimes we talk about people not cooperating or rejecting some interventions, etc. But sometimes it's because they do not know, they do not have that kind of information. There's mistrust. Sometimes we come in with our expert views, but then they are not too sure whether we mean well for them. And that is why we are saying we need to engage them and most importantly, listen to what they have to say so that we have this two-way sort of engagement. Infodemics is the new kid on the block, looking at misinformation, disinformation, rumors, among others. Complacency is a word that is thrown out there a lot. Community resistance, again, a terminology that is used, but like I've said, sometimes when you get reports about community resisting or complacency, we always need to dig deeper and find out the whys. Why are people resisting? Why are people not willing to take up interventions that we are providing so that we address the underlying factors? Then fatigue has been a big one, and then uncertainties and fears. So in terms of the principles, communication in a timely manner is extremely important because it promotes transparency. Listen, listen, listen. I've alluded to listening earlier because it is the only way we'll get to understand what the community feels, what they are thinking, and agree on how to address this, and in the process, ensure respect both ways. Planning with the community, again, community engagement, involving them, ensuring fairness, equity, and this is why the PAMIs is important, so that if in a country we have an outbreak in just one district or in one sub-district, we need to ensure that the response is equitable to, is fair or equitable to the areas, so that we may have more response or more activities in the hotspot or the the PAMIs that have been identified. Ensure participation at all levels. When we talk again about community engagement, most of us think of the village, but a community is much broader. We need to engage policymakers as well as any other leaders at different levels. We also, of course, have other communities as, for example, institutions, and not necessarily just in the village. Empathy is key, not very easy. We should always try to fit into that person's shoe so that we are not talking at them, but conversing with them and trying to understand their position. It's not always that easy. So if we try to do all this, then this can help us in building the trust. Remember, one of those reasons why we want to conduct RCCE is to gain trust from the communities. And because they already mistrust, whether it is the responders who may be government or other partners. In addition to what is in the previous slide, any communication products or actions should be aimed, that are aimed at the community need to be adapted to the situation. Again, Katie referred to context. So the setting is important, whether it is in the community, in the village, the religious institutions, among others, as I already alluded to. This is, again, not an exhaustive list, but just a select few. We need to adapt them to the level of education, age, sex, socioeconomic status, common languages and or dialects. Again, Katie referenced this. There are a lot of guidance and messages that come most of the time in English or the official languages. So in terms of preparedness, this is the time to look at some of the standard messages. Of course, when there's an outbreak, we then have to still go in and listen to people and hear what the concerns are and address those that may not necessarily be in the standard questions or messages that are available. But upfront, we can always translate some of those key ones. The most appropriate means of communication needs to be considered. Is this person able to only understand oral messages? Can they read and write? Do they not hear, for example, hearing impaired, and therefore can only do visual? So that needs to be considered. It may not always be possible for example, for the whole country, but then when there are those identified areas, if, for example, the problem is in a school where most of the children are, or all the children are hard of hearing, then obviously we need to go visual. Trusted and accessible channels and stakeholders. So, sorry about that. So we need to consider this as important because not every channel is available to everyone. And then we also have stakeholders within areas. And later on, I'll be looking at ensuring that we know who is working where. Then the materials, etc., must also be pre-tested before use and before mass production. And of course, this is more feasible when we are looking at preparedness. Sometimes when we are in response, we are in such a rush that you almost want to move out. And many times we do move out with materials that have not been pre-tested. So just a quick look at what exactly we need to do in terms of preparedness. That is risk communication and community engagement before a cholera outbreak. So it's this will help to prepare the community for a possible outbreak, and the communication should take place at multiple levels, national and subnational. So there's been a lot of reference to the health facility. Most of the time you think health facility and we talk about the healthcare professionals, but there are so many others at that level, has been alluded to by our colleagues. Then there's community, where we need to create awareness about the risks, among other areas that we need to emphasize. Always remembering about the context-specific nature of all this. So in addition, we need to then strengthen the interagency RCC partner coordination at national and subnational level. In some countries, we are talking districts, others provinces, others counties. So don't worry if yours is not mentioned here, but this is key so that we are working together and ensuring that our response is coordinated and not everybody running their own show or moving in different directions, sometimes maybe even contradictory. Mapping the risk communication and community engagement partners is key. Mapping partners is important across board, but for us as risk communication, we can start by knowing who is doing what where, so that especially for the areas that have been mapped out, we can be clear that there's somebody working there, and also to try and ensure that if there are any new players, we are not having them join a region where there are already so very many people. Then developing or adapting plans for cholera preparedness, in addition to the identification of the priority areas for multiple intersectoral interventions. We also have the planning, which was the main focus for the webinar last week. So it is important that we look at what is available and update it. We don't always have to start from ground zero. Conducting rapid assessments for social and behavioral data, very important. And this is something, again, that we can get to do early or in preparedness, so that at least we know what it is that the communities are already aware of. And then identifying trusted, accessible communication and feedback channels. I already alluded to this earlier. Developing, adapting, or reviewing existing tools and messages for cholera prevention. Facilitating community engagement meetings to identify areas to be included in the development of action plans. Of course, communicating what we already know. There are times when there's something that is still not clear. We also need to make that clear so that we don't make up responses, but ensure that we follow up and get the right information if it is a message that is required to be clarified. And then creating capacity building opportunities. As this is, again, easier before. And so we need to do this. And these are some of the examples of people that we really need, whose capacities we need to build. And then strengthening community feedback systems. Most of the time we rely on what we are seeing online, maybe on X, or maybe some other social monitoring platforms. It's very important also to ensure that we have the offline one. In certain regions, and I will specifically speak for the Afro region, a good number of countries, when you get to the far end, places that are very rural, you may not be able to, they may not be able to access messages on online, and therefore that we require to hear from them by asking them, or as you talk to them, what are some of their concerns that may need our attention. So what is it we are going to communicate? I've alluded to a lot of these, but I'd just like to point out, especially in terms of infection prevention and control, I'll not repeat what has already been mentioned, but it is going to be important to focus on the personal and environmental hygiene, so that those details that we already have in the GTFCC document, we need to look at that, translate them, and have them ready, talk about them to people in terms of prevention. And then oral cholera vaccine demand generation, also very important. In terms of treatment in this area, I'd just like to say a little more around the ORP and maybe even also the CTU, CTC. Yes, these have not yet been set up, and that is why during preparedness, we need to prepare communities to know that these are facilities that would be very useful when people, in case of an outbreak. And then for some of them, the ORPs or CTU, it's also good to engage the community so that we identify together the best place to put these structures, so that we don't arrive there as responders, put up a structure, and then the next morning when we come, we find the community has brought it down. So it's important that we use any opportunity to communicate about these risks. So as I get towards the tail end of my presentation, it's just still good to remember that RCCE is essential for driving change in behavior and practice within communities. It is essential at all levels of intervention, as I've already alluded to. And the best thing is that it helps to build trust especially when we go the two-way communication direction. So as I mentioned, the next few slides have tools and resources. I've talked about collecting behavioral data. These links will send you to where you can find sample questions. At the end of the day, you must contextualize them based on what you need to learn from the community or the data that you need to collect. There are Q&As that are available in different languages. And then we also have a message bank. Again, when you go into this, we are not saying you translate everything, pick what is relevant for your country, for your region. Cholera thematic kit, again, if you click that, you'll find a lot of resources there. Community feedback and social science in public health emergencies, again, very useful. And then additional materials, some that have already been shared by other presenters. And with that, I say thank you, obrigado, merci beaucoup. Thank you.
Thank you very much, Dr. Susan, for that very wonderful and very great presentation on RCC, especially to get us prepared before an outbreak occurs. So, colleagues, ladies and gentlemen, it's very important that we are ready. We are not supposed to be caught unawares by an outbreak. So at this point in time, we are going to give a few minutes just for questions and answers. And I know that there have been quite some very good in-depth discussions in the Q&A. And I want to encourage everyone, please post your questions in the Q&A and you get very comprehensive, rich responses from the panelists. So at this point in time, let me just allow 2 or 3 people to ask questions live. And like I said, we are giving preference or priority to our Portuguese speaking. So please, if there is anyone who has a question, especially in Portuguese, we want you to ask, indicate by raising your hand. Already we have 3 hands raised. So I'm going to ask them to quickly ask their questions, and I'll start with Tamara Hatuma. Tamara, after Tamara, then we have Kanikon, Okeo, and then we have Valentine Kiki. So we start with Tamara. Can you please go ahead and ask your question?
Good morning, Dr. Kapaya. My question goes to the first presenter. I joined in a little bit late, but maybe you could go back to the kits and where the cholera kits and where they need to be placed. By the time I was joining, he was talking about the central kit being for community, did he say, and then the peripheral, that breakdown, please, if you could, just a summary. Thank you.
All right, I'm sure Dr. Masina has speaked and Katie also has speaked. We can go to the next question before they can respond. Kel, can you please go ahead and ask your question? Carl, can you hear me? You are muted. Okay, can we proceed to Valentine? Valentine, can you ask your question, please? Valentine, your hand is raised. Can you ask your question,
bonjour,
please?
Pardon, je n'ai pas demandé la parole.
Okay.
Merci.
Proceeding. Okay. Okay, Sidibe.
Oui, je suis là.
Sidibe, you are muted. We didn't hear what you said.
Oui. Vous me recevez?
We can hear you.
Oui. Je voulais savoir si nous, on pouvait avoir la version française de ces présentations après cette séance. Parce que, au fait, les séances précédentes, on a eu les versions de présentation, mais tout est en anglais et nous, on a un peu de difficulté par rapport à la compréhension. Merci beaucoup.
Okay, so point noted. Thank you very much. We'll work on that. I think those are the only questions. So, Dr. Messina, Katie, the issue of the kits and where to place them, the central, the peripheral, and the community kits. You can take it up, please.
Okay, I think this actually would be very helpful if the person puts it in the chat, in the Q&A, and we can answer, but very quickly. The ORP kits, which are the community kits, are ORP kits. The periphery kits are designed for CTUs, and the central kits are designed for CTCs, but we'd be happy to put that in the Q&A as well for reference. Thank you very much.
Thank you very much. So Tamara, please put that also in the Q&A and the comprehensive answer will be provided. I'll just give chance to one person. After that, we go to the next. So this one is Afilao.
Good morning.
Good morning.
This is Philo Adiago. I just want to ask concerning the laboratory diagnosis of Vibrio cholera. With the examples of laboratory that I've seen that there is little to no facility for the diagnosis of Vibrio cholera. Most labs doesn't even have the plate for it. Like, I'm assuming the epidemiology of cholera currently is underrepresented, and what are the systems in place to curtail that?
Okay, so very important question, and I'll urge you to also put it in the chat, but also to indicate to you that we are going to have a comprehensive webinar that is going to talk about surveillance and lab, and that will give us the new strategies for cholera testing, for cholera diagnosis. So in a nutshell, so for the purpose of confirming cholera outbreak, we use culture. That's what I can say for now. So we use culture, and for screening, we can actually use RDTs. But a comprehensive webinar is coming on the 23rd of November, where we will talk about surveillance in details, and we'll talk about lab and what is required in the lab. Okay, so unfortunately, I'm seeing quite a lot of hands coming up. I want to ask you please to post your questions in the Q&A because we are running behind time, and I now want to call upon Pierre Focassi to give us a presentation on the GTFCC recommendations for WASH activities and also WASH in preparedness, response, and development. Pierre, please go ahead. The stage is yours now. Go ahead, Pierre.
Yes, Fred, can you confirm you can see the first slide?
Yes, we can see the slides. You just put them in presentation mode.
Okay, super. Good morning, good afternoon, everyone. I'm Pierre Focassi. I'm with the WASH team, UNICEF Regional Office, and I will give you a brief orientation on...
Pierre, there's a lot of feedback from your side, the volume. There's a lot of feedback. I don't know what is happening there.
A lot of feedback. Okay, maybe I should stop my... Is it better? Fred, is it better?
It's like there's still some feedback. I mean, Mohamed, what is happening with Pierre?
Pierre, on entend beaucoup de friture. Vous avez certainement un appareil électronique à côté qui est en train de parasiter votre voix.
Ok, j'éteins. Is it better now?
Non, on continue de recevoir de la friture. Est-ce qu'il y a une autre personne qui est connectée ou Ou êtes-vous connecté avec votre smartphone ou un autre ordinateur?
Non, ça vient pas de moi parce que j'ai pas de friture, j'ai pas de bruit là ici. Can you hear now?
We can hear you,
can
but
hear,
there is
but
a lot
still-
of crashes.
Okay, very weird. So let me try with another device. Sorry about this. Just a moment, a microphone.
Je crois qu'il y a un retour de son dans votre ordinateur.
Est-ce que c'est mieux maintenant?
Non, non.
Est-ce que c'est mieux? J'ai changé.
Il y a un écho qui revient.
Qu'est-ce que ça peut être?
Is it possible, Pierre, if we can ask Danish to start the cut, then you come on last? Is that okay?
Yeah, that's fine. That's fine because the audio worked before. I'm removing the background noise. Can you hear better?
Yes, it's now
Yes,
better.
now it's better.
Okay, so apologize for this technical problem we had. We had definitely prepared this before. So I'll be brief to give time to the presentation on CATI, which is a very critical one. So I will be presenting on behalf of UNICEF a quick orientation on what is a WASH, water, sanitation, hygiene, eau, assainissement, hygiène, saneamiento et hygiène. All right, and what I insist is I will put many links so you can have access after when you receive the document to the technical documents, okay? So first of all, WASH is a human right. It's very explicit in many legally binding documents, and it has been adopted by the General Assembly as in a resolution as a human right to water and sanitation. But it's also a sustainable development goal, number 6, with the objectives of reaching universal coverage in drinking water and sanitation and hygiene by 2030. Unfortunately, we are absolutely not on track to achieve these objectives. For more information, you can click on the link of the Joint Monitoring Project and look at the situation in your own country. Here are the key stakeholders engaged in both development and emergencies in WASH. The primary stakeholders obviously are the communities, and they are supported by a wide variety of secondary stakeholders. Okay, the consequences of poor WASH conditions, meaning lack of access to protected water points, lack of access to safely managed toilet or latrine, and lack of access to soap and other hygiene items are really critical, as you can see on the slide. First of all, for dignity, for mobility, mortality, undernutrition, education, and there is also a high cost in for the societies, in particular due to death and and also the morbidities, I mean, what we call the nosocomial diseases. Sorry. Can you see my screen? Yes.
Yes, Pierre, we can see your screen.
Okay, and a particular attention should be given to girls and women. As you know that they have often the chore of fetching water, and they have subject to sexual violence or abuse, etc. Okay, so WASH is not only water, sanitation, and hygiene. There are many subsectors. So I'd like you to take a short quiz. I brought here in the 3 languages. And I'd like you to take the quiz. What are the 7 WASH subsectors? Quels sont les 7 sous-secteurs de la WASH? Quais são os 7 subsectores de WASH? Please, can you send the quiz? You can read it in the meantime, and the quiz will appear. If it doesn't appear, I will go directly to the solution, right? Okay, I'll go to the solution.
We do have the quiz.
Ah, okay, I don't see it on my screen. Okay. Okay, just let me know. I cannot see on my screen the quiz. So tell me when it's ready and we'll go to the solutions.
People are still voting. Do you ask me to stop?
No, just give them 10 more seconds.
Okay.
Quels sont les 7 sous-secteurs? Donc, vous pouvez ticker, mais pas plus que 7, s'il vous plaît. Okay. Moving to the solutions, you can see in green the solutions. Of course, food is not part of it, shelter obviously not, and drainage, no, it's not WASH, it should be taken by the urban and settlement planners. So now let's, basically all these 7 subsectors are detailed in what we call the Sphere Handbook. It's the Sphere Handbook is the most famous tool for implementation of humanitarian WASH, nutrition, health, shelter, etc. Response, including in the last there is the last report, you have one related to public health emergencies. It's in 3 languages and you can access through the links. Okay, so let's go quickly. As you can imagine, why it's important, the hand hygiene and the hygiene items are important in times of cholera. Here you can see the hand non-washed hand and without hand washing put on the Petri dish, and we observe the development of colonies of bacterial colonies. Okay, they are not all pathogens, but many of them are pathogens. No need to explain why water supply is important, and in particular, water supply that are resistant to climatic events. Excreta, basically, this is the main source of contamination. So management of excreta, meaning not only the toilets, the safely managed toilet, as you can see on the upper right, where there is a lid to protect from flies. But also, if there is open defecation, this should be controlled. Absolutely, we cannot leave the open defecation threatening the health of people until sanitation is in place, but it takes time, especially in emergencies. Vector control is partly for wash, partly for surveillance, health, etc. But for cholera, obviously, you look at the flies and the maggots that are vectors of transmission of cholera. This should be absolutely avoided. That's why we're talking about excreta control and especially for mitigating the risk. Okay, of course, stagnant waters and is important to drain and to eliminate, but sometimes it's impossible when you have camps or villages that are located in flood-prone areas. So this is about preparedness. What happens if your settlement or your village is inundated and the latrines are, you can see on the right, are basically flooded and the water is contaminated. So this is absolutely critical. Solid waste management, of course, is part of WASH. And finally, the importance of WASH in infection prevention and control in healthcare settings. In emergencies, and you will see at the end of the document, there are many technical references of WASH and IPC in cholera treatment centers, but also in development. And I give you here the link to the washinhealthcarefacility.org, where we have the WASH Fit tools for healthcare facilities. Okay, now moving to prevention and preparedness quickly. What's important in this phase is critical, is really to learn from the previous outbreak, to start pre-positioning or replenishing the supplies. We talked about the task force, we talked about contingency planning, and to prepare all the SOPs, the guides for implementation, the job aids, etc. And this material should be used for in courses, in refresher courses. Okay, we should train our WASH partners to use the checklist, to use the CATI job aids, in particular in two settings, in healthcare settings and in communities. Okay, we'll talk about it. I'll go quickly. Here, of course, we have a role to play, WASH partners before the outbreak, during the outbreak, and after the outbreak. I will not read all the imperatives, but these are here, and you will have access to them later. Importance during outbreak is not only to treat the cholera, but to map what are the sources of contaminations and what are the transmission pathways. And this has been done for many years. This map is about 170 years old, and it's from London, one of the last big outbreak in London. It was done by Dr. John Snow. But nowadays, we can use other tools like SIG tools or Google Maps tools to map the cases and to find what are the likely cause of sources of contamination. That can be a market, that can be a water point, that can be latrines, etc. Of course, importance during outbreak and to be prepared for it is 100% of water supplies should be purified. Okay, no way people drink non-purified water. There are different ways to do it: house to house, bucket chlorination at point of collection, and also bulk chlorination in water systems. Monitoring is critical. You should be ready and train your team to use the different chlorine product, chlorine testers. SOP is a must in any kind of distribution. Bucket is not necessarily, especially if it's open bucket, but basically narrow-necked, especially the jerry cans, or a bucket with a lid and a tap. Well, we don't go into details, but this is during outbreak when you have to address the case households and the immediate neighbors with cases. I think we don't have much time for the quiz. I prefer to give more time to our colleague from MSF. And basically, these are the settings where the WASH partners should have a role to play. In healthcare settings, at the household with the cholera case, in the immediate surrounding of the household, what we call the cholera ring, in the whole community, in all communities at risk, with or without cases, and also in special events when, for example, on the markets, funerals, and gatherings. Okay. Okay. I skipped this one as well. It's about chlorine products. So it was a quiz. You can take it later. But you know they have different chlorine solutions based on the risks, obviously. But be careful of not over-chlorinating, especially the hands. Use only the 0.05 for hands. As I've seen, sometimes they use high concentration. It's not good. Okay. All right, I will stop here. These are the references. There are several pages of references for your own work. And I wish you a good continuation of webinar.
Okay, so thank you very much, Pierre, for very great presentation. We really appreciate, and WASH is actually very key when it comes to cholera. So we are struggling of cholera. It's because we are not doing fine on WASH. This is actually key for us to be able to actually understand and know what to do. So quickly, I'm going to call upon Danish from MSF to give us a presentation. Now, this presentation, ladies and gentlemen, is very important. It's talking about the CATI approach. This is a new approach that is very important to the control of cholera outbreaks. So Danish, please take it up, and the floor is yours.
Thank you very much, Fred. Good afternoon, good morning, everybody. My name is Danish from Doctors Without Borders, and I'm going to present case area targeted interventions, CATI approach. To start with, so basically, it explains that the early cluster detection of cholera cases can trigger a rapid localized response in the high-risk radius around one or several households to reduce the transmission sufficiently to extinguish the cholera outbreak or reduces its spread. CATI basically emphasizes WASH and health interventions to address routes on short-term and long-term basis and are implemented in a ring radius around the primary case household. CATI approach should be launched within 24 to 48 hours of the first case or cluster observed. So the reactivity is the key when it comes to CATI response as well. We're going to discuss all these things in the coming slides as well, much in detail. So the justification for these case area targeted interventions is the clustering of cases observed in the appearance of a cholera during epidemics as well. So basically, once we have cholera, we started to have clusters of cholera in different locations. And the current evidence supports a high-risk spatio-temporal zone of 100 to 250 meters around the case household for approximately 7 days. CATI interventions has the potential to reduce the number of patients and therefore the deaths, as well as to reduce the duration of epidemic and therefore the total cost of intervention as well. So if CATI is implemented within a good time, you can reduce morbidity and mortality. You can also reduce the duration of epidemic, as well as the total cost and resources which are needed to respond to the outbreaks as well. Here you can see on the left-hand side, a graph which explains that the early intervention can reduce the rate of cholera incidence. You can see by responding early to a cholera outbreak, we can clearly bend the curve of an outbreak as well. which is highlighted in the purple color. And on the right-hand side, you can see that the CATI interventions are implemented, especially in the early and the late stages of an outbreak, when there are few cases. So we don't implement CATI when you have a lot of cases. The whole rationale behind of CATI is to respond early so you can contain the outbreak. Once you get into much more cases, then we go to other strategies to respond to cholera. Quickly looking at what is a high-risk radius. Basically, 80% of cholera transmission happens within the household. And the households with the primary case has 100 times relative risk of contracting cholera. You have 36 times relative risk within the 50 meters in the first 3 days. You have 6 times relative risk within 50 to 100 meters in the first 3 days, and the 5 times relative risk within 100 to 150 meters in the first 3 days as well. So basically, as you go away from the primary case household, the risk starts to fade as well. And that's the rationale basically behind of CATI approach as well. They need to contain it in this ring radius or in the target zone as well. Sorry. So the selection of the ring radius or the target zone to roll out CATI. So basically, high-risk areas or ring radius is likely to vary between urban and rural areas. The radius of the ring is defined according to the local context and operational constraints as well. The ring radius is basically a guide. It's not like a hard and fast rule, it's a guide. The team in the field need to decide which households should be in the ring or not based on the local features. For example, up to the given road, river, or path, based on the team leader's assessment as well, which households are still at risk. And based on the local context, for example, maybe sometimes the whole village can be the part of CATI rollout as well, because in villages, the houses are quite far apart. So in the radius of 250 meters, you will just get maybe 2 houses, and in the whole village, you have 20 or 30 houses as well. So it's purely depending on the context with the ring radius as a guide. Then the CATI approach is basically a multi-X approach. And the first X of CATI approach speaks about standard interventions to reduce the household transmission. The key activities in the house to reduce household transmission includes risk communication and community engagement. It includes hygiene kit distribution. It includes transmission context assessment or sanitary surveys or WASH, trying to understand what are the key drivers of this cholera and how people are getting water and sanitation and everything. And referral of severe cases to the nearest CTC or CTU from the household where you are going to visit. And also referral to ORP points as well from the household as well. The second X of the CATI approach speaks about standard interventions to reduce the community transmission. Here, basically, we are speaking about active case findings within the community. We're speaking of screening and confirmation. We speak about ORPs within the communities, oral rehydration points. We speak again about referral of severe cases to the nearest CTC and CTU, as well as transmission context assessment of WASH within the community as well, which just explained in this previous presentation. The third X of the CATI approach is not a standard one. We call it a non-standard intervention to reduce the household or a ring transmission. So in the third X, we speak about the household and the ring as well. And the first thing we speak about is a single dose antibiotic in primary household or in adjacent households if needed. So basically, the rationale between the antibiotic is that it's given to the severe cases, it has an immediate effect. For moderate and mild cases, it doesn't let them go to severe cases as well. And also people, let's say asymptomatic, if antibiotics are given, they will be stopped shedding Vibrio cholera when they move around in the community. But again, here we need to see the issues with the antimicrobial resistance as well, and also if it's accepted at the national level or in the communities as well or not. The second non-standard intervention is single dose OCV. And basically, it is having more a preventive effect where vaccine takes few days to be active, but it helps to prevent further infections during this outbreak or in the near future waves as well, which are coming in future as well. So it has more like a protective effect on the people. As we know that we have a global shortage of vaccines and more using for a reactive campaign. So if we can secure some vaccines for cholera CATI approach, it shows that it has some effects as well. But also oral antibiotics and OCV to be used according to the national policy. And if they are not allowed, CATI can be implemented without these two as well. So the CATI implementation strategy, we speak about epidemiological surveillance within the communities through health centers, active and passive. We speak about confirmation through lab tests, but CATI can also be implemented on suspected cases coming on the case definition. You speak about GIS. It's very important to get the coordinates of the households and put the ring radius and all these things. Risk communication, community engagement, targeted reactive vaccine, WASH, and antibiotic therapy. So these are the key strategic pillars to implement CATI. Now, before implementing CATI, it's very, very important that we need to prepare for it. We cannot go and implement CATI if we are not prepared. For example, preparation of national CATI guidelines and protocol, which is part of the cholera response as well. All stakeholders should have a clear understanding of CATI approach and their roles and responsibilities. Identification of POMIs or hotspots. Where do we want to implement CATI based on the institutional memory or environmental vulnerabilities or other indicators? Setting up of CATI rollout team, depend on the context. It could have health, WASH, IPC, GIS, others, vaccinators be the part of it as well. Training of trainers, very, very crucial for all the team to be trained properly. Agreed data collection tool, so it's a harmonized data collection tool used by different stakeholders. Pre-positioning of supplies, so it is very critical, which includes your hygiene kits, your vaccines, your RDTs, all the rest of the things which are needed for the rollout of the CATI. CATI logistic and resources, which includes vehicles, bikes, activities, incentives, and everything, and others based on the context, because we need to implement CATI within the 24 and 48 hours. So the preparation is something which is must. Then let's see what is a primary household and what is an adjacent household as well. So the primary case household is a group of people living in the same unit or group of adjacent units a single head of household is responsible for. And in this diagram, you can see we highlighted it in red. You have directly adjacent household, which households in the unit that directly surround the primary case household, we also call them close neighbors. Sorry, they are highlighted in the blue color. And then you have households in the ring, which are in yellow. Both household adjacent and the ring, they are at highest risk of cholera. And the household just outside of the ring, they are having elevated risk, but they are not the part of the CATI approach because it has to be done in a limited area as well. Now, rollout of CATI, which type of interventions need to be rolled out in which house? First, let's speak about the primary case household, but before even starting, we need to meet with the community leaders to activate CATI. And CATI to be started within 24 and 48 hours as well. So in the primary case household, we speak about vaccination, we speak about hygiene kit distribution, we speak about antibiotic therapy single dose, we speak about RCCE, risk communication and community engagement. We speak about active search for other cases in the household and referral to nearest CTC, CTUs or ORPs as well. And transmission context assessment or WASH or sanitary assessment within the household with a primary case. So these are the key activities to be rolled out in the primary case household. Then next, going to the adjacent households as well. Here we speak about vaccination, we speak about hygiene kit distribution, we speak about antibiotic therapy if needed. We speak about referral cases to nearest CTC, CTU or ORPs, WASH or transmission context assessment, and risk communication and community engagement. So these are the activities to be rolled out in the adjacent households. And going to the households in the ring, here we speak about vaccination, hygiene kit distribution, referral to nearest CTC, CTU or ORPs, WASH or sanitary survey or TCA, and risk communication and community engagement. So basically, as we get out of the primary case household, the interventions goes a little bit lesser. We see we are not giving any antibiotics in other households in the ring, and because of the AMR, and also it's a very limited use, but it's also depending on the policy of the national of the country or national guidelines. One important thing is that findings from the WASH assessment should be shared with all relevant stakeholders as soon as possible for immediate follow-ups and actions, because sometimes we do CATI and then we forget to share all this information, and this information just stays in our computers. Here I'm going to give you a quick example of how a hygiene kit looks like, which is an example from South Africa in a recent cholera outbreak. So in terms of hand washing, we speak about soap bars, one for each in a family member, and a bucket with lid and tap for hand washing, which can also be used to store water. We speak about RCCE, all IC material, which needs to be there to use the things in the hygiene kit, cholera prevention and everything. We speak about ORS, we speak about surface cleaning, which includes your liquid soap, your bleach, and your clothes. We speak about water disinfection, which could be aqua tap, flocculants, chlorine solutions, and we speak about jerry cans, at least 20 liters for the storage of the drinking water. But this has to be harmonized with different partners and stakeholders working for the cholera response, as well as to the local context as well. So, example of CATI schedule, how it's going to be. The first is the detection of a primary case at the CTC in a health facility or in the community. The day 2 CATI teams travels to the site and performs ring mapping. The CATI teams goes to the site, does introduction, starts the implementation. And the day 3 is basically the implementation and finalization of CATI. Just remember that ensure all supplies and equipment is to be there on the site. Travel time to be considered as well. Additional time needed for introduction or GPS mapping and trained are charged. These are some of the things which were coming out from the previous CATI rollout as well, which were neglected and having a huge impact in the delay of CATI rollout. Then, once CATI is finished, we speak about monitoring and evaluation of CATI. Post-intervention monitoring is very important, but often challenging as well. We can look into the incidence of positive RDT cholera cases in targeted rings. We can also speak about incidence of cholera deaths in the ring after the CATI approach has been implemented. What was the overall coverage of CATI? What is the incidence of positive RDT cholera among household contacts of the first case as well? We speak about use of hygiene kits and health and hygiene education of the status of the community, if they know how to use hygiene kits and what is their health and hygiene status after all these interventions. Follow up on wash recommendations and others based on the how to stop CATI approach. So basically, indications for stopping the CATI strategy includes declaration of end of a cholera outbreak. It also includes sustained inability to consistently respond to case clusters within 7 days of alert. Like you are delayed, you wouldn't be able to respond to cases immediately. And the target is achieved as well in terms of completion. If the area has been treated more than 3 months ago, the CATI can be re-implemented. Why we say that? Because if you have implemented CATI and then you have more cases within 3 months, it means that the overall WASH situation is again very bad. That's why people are contracting. And maybe health and hygiene education is not that great. So we need to go back and strengthen these points as well to make sure that we are trying to mitigate the risks and vulnerabilities in that area. I am going to share with you some of the lessons learned from Malawi, Mozambique, and Zimbabwe UNICEF CATI rollout, which was published on August 2022 in 2023. So the good relation between all relevant stakeholders is required to ensure CATI success. It's just not one person's job, it's a multi-sectoral approach. Accurate data collection from health facilities, especially the addresses of the patients, and field interventions is critical. Strong leadership at implementation level, which includes government, provincial, district, and others, is very, very important for a successful rollout of CATI. Involvement of local leadership from the very beginning is very crucial. Clear set of indicators, reporting frequency, and harmonization of indicators across partners is very much needed. Strong support and follow-up required after CATI TOT to ensure success of the approach, because once we give the training and then we forget, and then cholera happens 2 years after. We need to do a proper follow-up as well, so the people are well aware of what they have to do to roll out CATI as well, and others based on the local context as well. Here, I'm going to give the last example from the CATI rollout, which was done by MSF in Congo DRC. The implementation of CATI was done with vaccination between April 2022 and April 2023. In total, 118 ring interventions were done, implemented at 5 sites in 4 provinces. It was a multi-sectoral approach, and 4 MSF sections are also involved in the response of in rollout of a CATI approach as well. So the preliminary result shows that the CATI initiated within 2 days' time. Vaccination started in 3.5 days. 89% of administrative coverage for the first vaccine dose was done. Discrepancies were there, however, in different rings of different sites in these things. But globally, what we have seen that the 75% of the rings did not get a secondary cholera case, which shows the efficacy of CATI and in containing the outbreak of CATI in these ring radius as well. So I think that's all for my presentation. Thank you so much.
Thank you very much, Danish. A very key presentation. And I know, ladies and gentlemen, this is one of the areas where we really need to up the game implementation of the CATI approach early enough in the outbreak. So Danish, we are very grateful, and just to indicate to everyone on the call that we'll be able to share these materials with our participants in the few days to come. So at this point in time, I know there's been a lot of good discussion that has been going on in the Q&A, but we are going to give chance for people to ask some questions. We can have live interaction. And again, I want to indicate that we are going to give preference to our Portuguese speaking. I may not be able to know exactly by name here, but have quite several hands that have been raised, about 7. So I know Suleiman asked earlier, but I don't know whether you are going to ask again. Suleiman, do you have a question? Suleiman, are you with us? Do you have a question? Okay, we can move to Patrick. Patrick Avev. Patrick, can you ask your question?
Yes, thank you very much, and thanks for the presentation. It was very enlightening, and it was just reflecting on the point that were raised in the implementation of CATI, particularly on the emphasis on adjacent households and so on. I was just wondering, within a context where the affected individuals could be in an urban setting where houses, neighbors do not exactly interact with each other very frequently, how would you go around implementing this? And just like we learned, for example, in the COVID, when you did contact tracing, sometimes the close persons to the individual is not exactly the neighbors, but maybe people who are friends, maybe 4 kilometers, 5 kilometers, or work colleagues 6 kilometers away from their dwelling places. How do you advise we go around implementing this? Thank you, and over.
Thank you very much for that question. And I'm sure Pierre and Danish have picked that question. The next in line is Kinanga Kiacho from Kinanga. Can you go ahead and ask your question, please? Kinanga, can you unmute if you are speaking? You are muted. Okay, we can proceed to Ali. Ali, your hand is raised. Can you ask your question? Ali, please feel free to ask in French, Portuguese, English. All languages are accepted. Okay, we can. Ali, yes. Can you go ahead, please?
Yes. For me, we ask about all the slides and the audios. I don't know if for audios they can translate before send for Francophone countries, or audios will be audios and video will be in English, and the slide can be translated.
Okay, thank you. We'll look into that. Thank you for that question, very important. Next, we have Miriam. Can you ask your question? Miriam, your hand is raised. Can you ask your question? Okay, next we can go to Susan. Susan, you can go ahead and ask your question. Susan, okay. We move to Mabuti Kethel.
Thank you so much. Thank you, Danish, for that powerful presentation. I was offline at some point because of network, so I got the guidelines for Kanti, but I missed the meaning for Kanti, the meaning of the initials Kant. Thank you.
Thank you very much, Danish. That question. Emeka, we can go to Emeka. I think Patrick has asked. Remeka? Okay, Emeka is okay. Lastly, we can have Evans Simukoko and Evans Simukoko. Evans, can you go ahead and ask your question? Okay. Thank you very much for those.
Hello.
Go ahead, Evans. Go ahead.
Yeah, thank you for a nice presentation. I'm from Tanzania. In cholera outbreak, especially in hygiene kit, I have a question in hygiene kit. Why do we use the bar soap instead of liquid-based soap for hand washing? I know there is a challenge of using bar soap. You have to touch it. Every person practicing hand washing have to touch that soap and for him or her to wash hands. So why are we preferring bar soap in hygiene kit? That's the first question. The second question, in a hygiene kit, there is a chance of adding other components in the hygiene kit. For example, water treatment kit, water treatment methods like in the kit we can opt of having aqua tab as part or as a component of the hygiene kit. Those are my two questions. Overall, I congratulate the presenter for the nice presentation. Thank you.
Thank you very much. I'll just give quickly, because a lot of more hands are coming up and we don't have time, but I also encourage you to post your questions in the Q&A. But let me allow Danish and the other colleagues that have been asked to actually respond to the questions. So Danish, can you go ahead, sir?
Yeah, thank you very much, Fred. Thank you very much, all of you, for the questions. I will start with the last one, which speaks about the use of the soap bar or bar soap instead of a liquid soap. So basically, what we have spoken in the hygiene kit is that we are giving one bar soap for each person. So it's not like one bar soap for a whole family. And this is during the CATI rollout as well, that we are giving one bar soap for each person. But again, like said, it's not like a hard and fast rule, and it's context dependent as well. If in some areas you want to change the content of the hygiene kit based on the context, is completely fine as well. Also, the second thing was that chance of adding other components like water treatment methods. So basically, we have added aqua tabs in our hygiene kit, but you can add other things based on the context as well. For example, flocculants or other disinfection materials. And also, these in the RCCE and IEC package, it fully explains how to use these disinfectants as well to chlorinate your water for potable purpose. So I hope I answered the question in terms of soap and water treatment methods. The second question, which I remember, is like CATI is basically very context dependent. And the question was that in urban settlements, maybe the households doesn't interact each other. Do we still need to do the CATI as the way we have explained here? So basically, again said, it's a very context-dependent thing as well. They might not be interacting with each other, but they might be using the same source of water, which is contaminated from the community as well. And also, depending on the institutional memory or the previous outbreak records as well, it can also give us a guidance that if we really have clusters of cases in those localities or not, or we get sporadic cases here and there. So I think this also can guide based on the context. And if the houses, if I understood well, if the houses are a few kilometers apart, then we don't implement CATI because then it doesn't fall into the rationale of CATI because it's going far away from the clusters and everything. One question where the voice was breaking was, what was the minimum standard? I couldn't get, Fred, do you remember that question?
The question was, what does CATI stands for? I think that was the question.
Okay, CATI stands for Case Area Targeted Interventions. So it's a targeted intervention around the case of cholera, case area targeted interventions. Thank you. I think these are the questions which I got from me, I guess. If there's anything else, I can respond.
Thank you very much. Well responded. There actually a few questions in the chat, but I think one that you may consider looking at, both Pierre and Danish. Basically, they just want to understand the difference between CATI and CLATI in terms of what constitutes CLATI and what constitutes CATI. So I think amongst the questions that are there, the others are saying kind of a comment that CATI sounds intriguing, 75% success is okay, but do you think the implementation time for CATI is too slow, 2.5 days to 3 days, hence the 75%? So there's that question, do you think we are slow in implementing the CATI? Okay, yeah, and then the last question probably for consideration is cholera patients with cholera. I think it's cholera in pregnant women. Can we give antibiotics, especially doxycycline? So those are the questions. And of course, anyone can chip in to support that. So please, you can go ahead, yourself, Pierre, and also case management, Katie, and Dr. Massina, and anyone else. Thank you.
Yes, I can speak maybe. This is Pierre, UNICEF.
Go ahead, Pierre.
Yeah, so one question about timeline. Of course, ideally you should go the day after if you can send a team, a rapid response team the day after, but all depends on the resources, the logistics you have in place at the facility or the district level. Voila. So ideally, yeah, the day after is ideal, but sometimes you have to deal with other emergencies. That's why we cannot do often the 24 hours or 48 hours. The difference between CATI and I think was a cluster, the cluster area targeted intervention. So when there are too many cases in the same community and not enough rapid response teams to implement complete a full CATI, this is where you implement the cluster area targeted intervention. That means it's an accelerated CATI. That means you try to visit all households, but sometimes you don't have the line list. You just have the community, the neighbors. So you try to implement as much as possible disinfection of the household, distribution of kits in the immediate surroundings. But when there are too many of them, this is where you have a cluster area targeted intervention, where you have a more rapid approach. You try to contain the transmission risks, the source of contamination, the transmission pathways, and it's more about having large risk communications, provision only of consumables, soap, and purification, water purification solutions, and possibly ORS. But it's not possible to conduct a CATI when there are too many cases. Over.
Thank you very much, Pierre. Very, very important answers. Any addition to that? I know Katie is actually has provided a response in the Q&A regarding pregnancy, CATI, and the use of doxycycline. Then there's the last one, probably two last ones. One, I think, is for Susan and possibly Katie. I think this is an appeal for RCCE in the GTFCC to have a technical working group for RCCE. So probably this is to, we take it up, and maybe this recommendation needs to go to the GTFCC. So Katie, you may help us with that. Is that submission in the Q&A? The other one for Pierre, and I know Mbayo is also here, and Danish. This question says some literature have it that the chlorine formulation for disinfection, here it says stools, probably this should be stool, is 0.5%. However, the presentation today gave us 0.2%. May I know if the current WHO standards for chlorine formulation is 0.2%? I think this is about Stu, Pierre or Mbayo or Danish.
So basically in cholera,
Yeah,
we speak about, Pierre, go ahead if you want. Yeah. We speak about three types of chlorine solutions, 2%, 0.2%, and 0.05. So 2% is basically for the disinfection of your excreta and also disinfection of dead bodies. 0.2% is used for the disinfection of surfaces and other materials, and 0.05 is used for hand washing as well. So maybe just to make sure that you haven't seen something linked to COVID-19 and you have seen everything linked to cholera, just to confirm that, because these are the three chlorine solutions we used in cholera epidemics, which is 0.2% and not 0.5%.
Thank you very much. And I think this is MSF, and UNICEF is in agreement and WHO is in agreement with the answer provided. So there could be one or two questions in French and Portuguese, but probably maybe I'm not able to read. Okay. Then is there a sustainable way of supplying or making provisions for the CATI hygiene kits to avoid shortages? This is a question coming from Dr. Sivanda Sitole. Is there a sustainable way of supplying or making provisions for the CATI hygiene kits to avoid shortages? Pierre, Danish, Mbayo, Katie.
I think provision of the hygiene kits depends on the organization which plans to roll out the CATI approach as well. And it's the part of the preparation also. So is there a sustainable way of supplying or making provisions for CATI hygiene kits? I think it's all the part of preparation, making sure that you have hygiene kits available. And without that, you're going to miss the key component of CATI approach without hygiene kits as well.
Thank you very much. Very good answer. Just to indicate, that's why we are doing these preparedness activities, is to ensure that we prepare, and we should be guided by the risk assessment. So once we do a risk assessment and we know the risk is high and there's a potential for a cholera outbreak, we need to quickly ensure that we plan for all this. So it is very, very important. Also to indicate the question regarding the materials. So the materials will be provided, will be sent to you in the next 48 hours, the recordings, the presentations, and they will be in the translated languages. So you'll still be able to get French, you'll still be able to get Portuguese and also English. So all is actually well with all of us. So ladies and gentlemen, want to thank you so very much for the time, but I want, before I call upon Dr. Mori to close this session, I want to just indicate that please, we are having another very important webinar on the 23rd of November, and this webinar is going to talk about surveillance, and there are lots of updates that the surveillance team wants to give to all of us to understand. So it's on surveillance and laboratory testing. So please make time for this very important webinar that we are going to have. We'll also be able, there was a question on certificates, we'll get back to you, but we are working on it, and we hope it works out, but I'm confident that we should be able to provide. And we ask you to make sure that you are present even in the next webinar, and we'll use that attendance probably for us to be able to support you with the certificates. So ladies and gentlemen, thank you for your attention. I would like to call upon Dr. Mori Keita, our Regional Advisor, Infectious Hazards from WHO Afro, to give his closing remarks. Dr. Mori.
Thank you so much, Fred. First and foremost, I would like to express my appreciation to all the speakers for the comprehensive presentations. My great appreciation also goes to all the participants who attended the meeting and helped to make it such a successful event. It's been a pleasure being with all of you today, and I thank you. Thank you all for your patience, and I wish you a very good day, and goodbye.
Thank you. Thank you very much, Dr. Moriketa. Thank you very much, everyone. Thank you, the presenters, for the wonderful work. We continue working together. So then we meet again on the 23rd of November to look at surveillance and laboratory. Goodbye.
Thanks, bye.